Good evening, everyone, and welcome to our course, Principles of Surgery. Today we'll be discussing management of small bowel obstruction, and it's my pleasure to introduce you today's speaker, Dr. Joaquim Havens. Dr. Havens is an associate surgeon and the director of emergency general surgery in the division of trauma, burn, and surgical critical care at Brigham and Women's Hospital, and associate professor at Harvard Medical School. Thank you, Dr. Havens, for joining us today, and we are looking for your presentation. Please, you may start when you're ready. Yeah.
My pleasure. Hopefully you guys can hear me okay and everybody can see the screen well. I was just mentioning this hopefully will be a very interactive discussion. The topic is fairly straightforward and very common. So I suspect that anybody who's has any training in surgery will sort of feel very comfortable with this topic. So ideally, I'd love to go into it in a little more depth with you specifically. So that's only going to work if you ask questions and if you kind of help me get a feel for where you guys are in your training and where you're interested in learning. So before we begin, I guess I will say I was able to travel to Kyiv in October of 2022 to help teach one of the advanced trauma life support system programs out there. I am very understanding of your position. I'm honored to be able to offer what little I can to help you guys with your training. So thank you for allowing me to participate in this. So I have no disclosures other than what I've just said. I kind of jump right in. I'm going to begin with the assumption that everybody here knows what a small bowel obstruction is. You're all junior surgeons or young attendings or surgical trainees. So I can't imagine you've made it this far without diagnosing and treating many small bowel obstructions. But if this is something surprising to you, just let me know. But we are dealing with the average patient who presents generally as an emergency with nausea, vomiting, obstipation, inability to pass gas or stool, and usually abdominal distension. And this patient may be very stable, or this patient may be very unstable. And our only real decision is, does this patient need an operating room emergently, or can we watch and wait? And as many of you know, about 80% of small bowel obstructions will resolve with non-operative management. So this is a predominantly non-operative disease, but it also turns out to be one of the most common and costly diseases that we treat as surgeons. So this is our basic list of causes for small bowel obstruction in the developed world. And I say in the developed world because it is completely different in low middle income countries in the developing world. In the developed world, adhesive small bowel disease far and away is the leading cause of small bowel obstruction. And why is that the case? You guys have a sense of why that would be different in, say, the United States versus in Africa?
Excuse me, you mentioned in the developed world or in the developing world, the adhesive is the most frequent?
It is the most frequent in the developed world, so in the high-income countries. And I would include Ukraine in that.
Maybe in the developed world, because there are a lot of operations performed, maybe due to opportunity of people to reach medical care and to get to be operated.
And that's exactly right. So the reason in the developed world adhesive small bowel disease is so common is because we have access to surgery. So the most common risk factor for adhesive small bowel obstruction is prior surgery. And in the developing world, particularly in low-income countries, without access to surgery, there will be a much smaller number of adhesive small bowel disease. So knowing that, then imagine in the developing world, in the low-income countries, what do you think the most common cause of small bowel obstruction would be?
Maybe hernia.
Yeah. So in much of the world, it is hernia. You're right. And that's because they do not have access to surgical repair. So this is sort of a dichotomy between different regions. But obviously there is adhesive small bowel obstruction in low middle income countries, and there is hernias in developed countries. It's just the proportions that are different. So it's important for us to understand the different types of small bowel obstruction. Now, I said at the beginning that our real decision tree, the thing that we need to understand as surgeons is this a problem that will resolve without surgery, or is this a problem that will require surgery, or is this a problem that requires surgery right now? So the vast majority of adhesive small bowel obstructions will resolve non-operatively, but very few small bowel obstructions caused by hernia will resolve non-operatively unless you can manually reduce them. So certainly understanding the cause of the small bowel obstruction will affect your decision-making process. I've included in here cancer and other causes, and we were going to discuss those a little bit more in depth because they're all things that you will encounter if you haven't already. So small bowel obstruction, these numbers are for the United States. We have over 300,000 admissions per year for small bowel obstruction, and that equates to more than 750,000 inpatient days, which effectively means about 3 days per patient on average. And that costs us more than $1 billion in healthcare costs. This is just in our country, and I'm guessing proportionally numbers are similar everywhere else. This is one of the very few research papers I put in here, and I put it just to demonstrate how important small bowel obstruction is in what we do. So I consider myself an emergency general surgeon. So I'm a general surgeon with additional training in trauma and in emergency general surgery, but probably 75% of what I do is emergency general surgery. So we looked at all the emergency general surgeries that surgeons do in the United States, and we sort of categorize them as what are the ones we do the most? What are the ones that cause the most death? What are the ones that cause the most complications? And what are the ones that generate the most cost? And when we do that, we actually find that there's only 7 procedures that account for about 80% of all the cases, complications, death, and cost. And some of those you would expect. They're colectomy, small bowel resections, gallbladders, peptic ulcer disease, lysis of adhesions, appendectomy, and exploratory laparotomy, meaning a laparotomy that you did not perform any other procedure with. And if you think about what we're looking at, this will make more sense. Now, volume, if you think of cholecystectomy and appendectomy, these are huge volume. These are large numbers of cases, but very few deaths and very few complications. So those are on the list because of their volume. Large bowel resection are pretty common and have a fair number of complications and death. So they're at the top of the list because they are large volume and large complications. And then at the bottom of the list, exploratory laparotomy is very uncommon. If you think about doing a laparotomy and not doing any other procedure, that means you do not find anything that you can intervene on, or if you find that there is nothing salvageable and that patient will pass away. those are not very common, but those are very lethal. So it's not the surgery itself that is lethal, it's whatever caused them to need that surgery that was lethal. I put this slide in really to talk about the fact that small bowel obstruction, if you look at that and try to find it on here, you'll actually probably find it in two places. Small bowel resection, number 2, and lysis of adhesions, number 5. So realistically, small bowel obstruction probably accounts for 2 of the 7 surgical procedures that cause the most morbidity, mortality, and volume. So based on that, I would say that small bowel obstruction is probably the most important emergency general surgery disease process that we will deal with. So the first part of that decision tree is, do I need to go to the operating room right now? And can we real quickly, I am making an assumption that everybody here has diagnosed and treated small bowel obstruction. Is that a fair assessment? Can you guys just real quickly say yep or no?
Yes, that's true for me.
Yeah, yes.
Okay.
Yeah.
Thank you. That's kind of what I wanted to get. I want to make sure that I'm getting the right words to the right people. So here is a case of a patient with a small bowel obstruction who has, let's say, peritonitis, hemodynamic instability, or significant metabolic acidosis. That is a patient that needs to go to the operating room. Now, it doesn't matter if this is 1968 or 2028. Those are signs and symptoms of a patient that we are concerned for bowel compromise. And so I think if you have a suspicion that there is ischemic bowel from any cause, that patient needs a surgery. The imaging here is actually a real nice one. If you look to the loop of small bowel on the left-hand side of the patient, you'll see that it's a piece of small bowel that is thickened. There is significant fluid in the mesentery. And if you look over to the opposite side, you see a very normal appearing decompressed loop of small bowel. So this is, you could almost imagine there's a band right here where my cursor is, if you can see my cursor, that's constricting the blood flow to this loop of bowel. This is an ischemic loop of bowel, and this patient will have severe pain, probably have acidosis, and depending on their reserve, will have some hemodynamic instability and potentially peritonitis. So this hasn't changed. This was how it was when I trained. This is how it will be for the people that we train, but this is a patient that needs the operating room for small bowel obstruction. This is something we see a lot of. This is the non-reducible hernia, whether that's in the groin or in this case, incisional ventral hernia. If you have a bowel obstruction from a hernia and you cannot reduce that obstruction, cannot reduce that hernia, that patient will need a surgery. If you have a suspicion that there is bowel compromise, they will need a surgery right now. In some cases, in a chronically incarcerated hernia that has not changed, you can wait, say, until the morning to operate on them, but you can't delay this. This is unlikely to resolve without a surgery. And I will say that when you have a loop of bowel like this that is inside of a hernia sac, it can fool you because it's sort of kept away from the rest of the body. And so that piece of bowel can be dying, but that patient might not develop peritonitis. That patient might not develop acidosis or hemodynamic instability because it's inside this sac, and the sac is sort of a little bit separate from the body. So you have to be very cautious. If you have a bowel obstruction and a hernia that you can't reduce, you can be tricked into thinking that everything's fine. The white blood cell count is normal. Their bicarbonate is normal. You might think everything is fine. And then when you do go to the operating room, you may find that that bowel is actually perforated into the hernia sac. So as a general rule, a small bowel obstruction due to hernia that you cannot reduce should go to the operating room. Now, this is the sort of the list of other causes of small bowel obstruction. So one of them that we see a lot as a cancer center is the malignant small bowel obstruction. So small bowel obstruction because of cancer. That can be primary or metastatic. I would say most of what I see is metastatic cancer. There are not a lot of primary small bowel tumors, but regardless of where it comes from, the mechanics are simply a mass obstructs the bowel. And effectively, we still default to our first rules, which is if there is concern for bowel compromise, if bowel is dead, if there's perforation, then surgery has to be considered. I say that a little differently. I say surgery has to be considered. I don't say surgery is mandatory, because now we're talking about patients who have a terminal disease. And so the decision to offer a surgery in a patient with a terminal disease is more nuanced than you have a bowel obstruction, therefore you need surgery. So any patient with metastatic cancer, even if they have what we would consider a strong surgical indication, you need to sit down. You need to talk with that patient. You need ideally to talk with their oncologist, and you need to talk with their family and say, here is the problem. This tumor is blocking your intestine. You cannot live for very long with your intestine blocked, but you have advanced cancer. You're undergoing advanced therapy for it. And at this time, it's worth talking about what's important to you, because a large surgery with bowel resection, with ostomies, may not be what you want at this time in your life. Those kind of discussions are incredibly important. If you don't do them often, they can be very challenging and very nuanced. We do them a lot. I usually allow at least 3 conversations of 1 hour apiece. So a conversation of just saying, here is the problem. This is what a bowel obstruction is. And then a second conversation, if time permits, a day later, or at least an hour of, so here's how we address trying to fix this. And then a third conversation of, let's talk about what's important to you and should we do this. These patients can still undergo medical management, which, as you know, just means nasogastric decompression, nothing by mouth, IV hydration, and serial abdominal exams. So you still have the same non-operative options, but these patients are less likely to be successful with that. It's not that they won't succeed, but they are less likely. And then I talk a little bit about the surgical options, because there are really about 6 things that could happen. And I talk about each one of these things when I'm talking about a small bowel obstruction due to cancer. I tell the patients, we might go in and go, oh my gosh, it's just scar tissue. And we lyse the scar tissue and everything's back to normal. You still have cancer. We are not performing a cancer surgery per se. We are relieving the obstruction. So it could be as easy as a lysis of adhesion. We may identify a small tumor that's causing the problem that we can resect and create an anastomosis, in which case the tumor is removed and your bowel is back in continuity. So we've resolved the problem. We may find that the tumor is obstructing and we cannot resect it, but there is healthy bowel everywhere else, and we can perform a bypass. For instance, an ileocolic bypass, a bypass from distended bowel to decompressed bowel. That still leaves the tumor in place and that leaves the obstruction in place, but it bypasses it so that you can eat a regular diet and resume therapy. We may find that there's nothing to bypass to, or that we don't feel safe creating an anastomosis and the blockage is distal enough, we can perform a proximal diversion, like an end ileostomy or a loop ileostomy, in which case you are still able to eat but you have an ostomy that will be for the rest of your life. The last surgical intervention we can do is a venting gastrostomy, which is simply placing a tube surgically into the stomach so that we can decompress your stomach. That does not relieve the obstruction, it just allows it to decompress. That tube is usually for life, and that tube does not allow you to eat. It allows you to take liquids for comfort. So this is only a way of replacing an NG tube with a gastrostomy tube so that patients can either continue on with their therapy or go home to hospice to pass away comfortably without a tube in their nose. And the last thing that may happen during a surgery for malignant bowel obstruction is that we just can't do anything. I've entered these cases where you can't identify any structures in the peritoneum. You can't tell if you're in the abdomen or not because everything is just coated in tumor. And I would say that being able to recognize that early and to abort the procedure early is very important, because if you start trying, if you start thinking, maybe I can get in, maybe I can get around this, maybe I could just get to something that looks normal that I can resect, you are more likely than not to put a hole into something, to create some enterotomy, to create a wound that will never heal, and take a patient who had a closed abdomen and an obstruction to a patient who has an open abdomen that's leaking stool onto their skin. And now there's no surgical option. There is no chemotherapy option because they have a fistula, and they will pass away in a much more uncomfortable state than if you had done nothing. Then there's some other causes. These are in some places common, in some places uncommon. There are things like inflammatory bowel disease, like Crohn's disease, foreign body ingestion, gallstone ileus, and intussusception. Gallstone ileus is fairly rare, but this is a picture of it. This is one of my patients. If you look at the loop of small bowel on the left-hand side, it doesn't look that abnormal, but you see the dots of air inside the middle loop of small bowel. If you can see the cursor, it's right there. That's a gallstone. The gallstone itself doesn't show up because it's just soft tissue density. But the fact that there's air in the middle of the gallstone is what you see. You don't see the decompressed loops, but you'll have to trust me, they're there. Gallstone ileus generally is a surgical problem. It will require surgery, and it's simply creation of an enterotomy, removal of the gallstone. I have never gone back and tried to repair the gallbladder duodenal fistula. Just those patients are generally old and infirm, and the fistula doesn't hurt them. So I just get the gallstone out, leave the fistula in situ. You're only going to cause them more problems by resecting a big piece of their duodenum. Intussusception, it's worth knowing that these are fairly common and can be very benign. We see them often on CT scans, incidentally found. So the presence of an intussusception is not necessarily a surgical problem. The presence of an intussusception with bowel obstruction or causing a bowel obstruction is a surgical problem and will require surgery to correct. Any questions so far? Alrighty. So we've kind of talked all around small bowel obstruction, but this is a little bit more specific now. I've said this a few times, but about 80% of patients with small bowel obstruction will resolve without surgery. I also use that 80% number to say that about 80% of patients who have had abdominal surgery will not have a small bowel obstruction. So I say 1 in 5 patients who've had an abdominal surgery will eventually get a small bowel obstruction. And out of those, only 1 in 5 will require a surgery for it. Does that make sense? Often our radiologists will use the term high-grade small bowel obstruction, and there's good literature to support that even the term high-grade, as read by a radiologist, can still safely be managed non-operatively. Remember, the most important factors for our decision about operative management of small bowel obstruction is, do I have suspicion that there is bowel compromise? Remember, peritonitis, hemodynamic instability, or severe acidosis. Now, this next one is important and has been evolving over the last 10 years or so, but orally administered water-soluble contrast. This is undiluted soluble contrast, not the 2 liters of contrast that you drink for a CAT scan, but actually drinking maybe 90 or 100 cc's of undiluted contrast. If it reaches the colon within 24 hours, there is a 97% sensitivity and 96% specificity that small bowel obstruction will resolve without surgical intervention. So we've, at the Brigham and at many places around the country, have created pathways in order to, within 24 hours, assess, will this patient likely be successful with non-operative management? And that is an oral contrast pathway. Current guidelines recommend that patients without resolution of SBO undergo surgery by day 3 to day 5. So that doesn't mean that occasionally a patient might go 7 days with NG tube decompression and then open up and not require a surgery. That is something that happens. But if you're waiting for all your patients until day 7 to operate, you're going to have a lot of complications from malnutrition, long hospital stays, prolonged ileus, and you will probably miss some patients that should have gotten surgery sooner. So current recommendations are 3 to 5 days. I generally recommend, if you've done a small bowel pathway and contrast does not pass, then surgery sooner rather than later. And Sophia, I see you raised your hand.
I want to ask you, did you do excretory scanning after contrast intake, like after 3 hours, 12 hours, and after 24 hours?
Yes. So our pathway is, at first, all patients suspected of small bowel obstruction will get a regular CT scan with IV contrast, and in most cases with oral contrast. That's just to make the diagnosis and to help us rule out bowel compromise. And then our pathway, which I will go into a little bit later, is to drink 100 cc's of Omnipaque, which is water-soluble contrast, or put it down their NG tube. And then we take x-rays at 8 hours, KUB, at 8 hours, and at 24 hours. And if it has not reached at 24 hours, we consider that failure of the pathway. And that doesn't mean that we immediately go to the operating room, but it means we begin the discussion with the patient that you are less likely to be successful with non-operative management, and it's time to start a discussion about surgery for this.
Thank you.
Yeah, of course. So I think we'll talk a little bit more about the pathway as we go forward, but there are some guidelines. They are old. These are the most current guidelines from the Eastern Association for the Surgery of Trauma and Acute Care Surgery. And these are from 2012, which means they are old. They graded evidence as level 1, level 2, level 3, based on the existing literature at that time. One thing that they did say is that a CT of the abdomen and pelvis should be considered in all patients with small bowel obstruction. And this is different than when I trained. When I trained, everybody said, if you suspect adhesive small bowel obstruction, don't waste a CT scan, just get an x-ray and you'll make the diagnosis. And while that's true, CT scans give you a lot of information. They're very helpful to, do you see fluid in the mesentery? Do you see thickening of the small bowel? God forbid, do you see free air? Is there a hernia that you missed? You know, sometimes subtle hernias are missed. So really a CT scan is the standard of care if you think there is a small bowel obstruction. They are pretty good this is a CT scan, identifying bowel ischemia, you might see a mesenteric swirl. You might find a mass that you were unaware of. So while you can save money by not getting that CT scan, our standard of care is to always get a CT scan if we suspect bowel obstruction. As we said many times before, if you suspect bowel ischemia, you take that patient to the operating room. If you do not suspect bowel ischemia, because you know that 80% of these will resolve non-operatively, then all patients who do not have concern for bowel ischemia deserve a trial of non-operative management. That again is level 1 evidence. The question of should I do this laparoscopically or should I do this open comes up quite often. This is in 2012, the recommendation that laparoscopic treatment is acceptable. And I will say laparoscopic treatment is preferable when it can be done safely. So safely means, do you have the facilities, the equipment? Do you have a surgeon who is comfortable doing laparoscopy? And then do you think you will have the conditions and the abdominal domain to safely do that? So if you suspect a small adhesion distally, and you think I can get there with a scope, it's very reasonable. If you think this is tons of adhesions throughout the abdomen, sometimes just an open surgery is better. Again, level 2 evidence, if you don't resolve within 3 to 5 days, you should go to the OR. There's a grading system for bowel obstruction based on clinical findings, imaging, operative findings, and pathologic findings. I can't say that we use this regularly, but it is something worth knowing. That is the American Association for the Surgery of Trauma and Acute Care Surgery has been working very hard to make what we do very standardized. And I say that in a good way, so that we can communicate, that we can better discuss with the patients and with ourselves the state a patient is in, but also so that we can perform good research and good quality improvement studies. If you're able to grade these, then you can say, well, at this institution, a grade 3 has this many complications, but at this institution, it's different. That gives you opportunities for quality improvement. So this is their grading system, grade 1 through 5. Like every grading system on Earth, grade 5 means the worst: perforation, peritonitis, free air, free fluid. So nothing surprising there. And grade 1 being the best, maybe it's partial, you're passing gas, you don't see anything on imaging. And 2, 3, and 4 are in between that. So kind of intuitive, to be honest. There are Bologna guidelines for the diagnosis of adhesive small bowel obstruction. These are from 2017, which is a little bit more current than the 2012. Same thing, using levels of evidence. This one, do you guys use, in the US, it's called Sepra film. It's a hyaluronate carbomethyl cellulose. It's an adhesive barrier that you can put on at the end of a surgery.
No.
No.
Yeah.
No.
Not surprising. It looks like a piece of plastic wrap, but it dissolves slowly. It's something that can be placed over the bowel or over the omentum, between the bowel omentum and the abdominal wall at the closing of a surgery. And it creates a little bit of an adhesive barrier. So it's been shown it does not reduce the number of small bowel obstructions, but it does reduce the number of surgeries required for small bowel obstruction. So we do use it when, truthfully, when we remember to use it. But it is a commercial product that's available for reducing the risk of needing a future surgery for small bowel obstructions. New guidelines also, as we said, say that plain films have very limited value in the workup and are not recommended. So this is a CT scan is recommended. Diagnostic workup should include a CT scan with water-soluble contrast. If no immediate surgery is performed, X-rays after 24 hours to contrast reaches the colon. This is, it's worth saying once more that in general, the contrast pathways that we talk about are undiluted contrast pathways. That's just, does the contrast without dilution reach the colon? When you do a standard CT scan with oral contrast, you're drinking 2 liters of diluted contrast. So it's much harder to tell on plain film if that has reached the colon. Sometimes you get lucky and you do a CAT scan and 24 hours later you get a plain film and you see contrast in the colon. Well, that's great, that counts, that's fine. But if you do the CAT scan and at 24 hours you don't see contrast in the colon, that dilute contrast, that doesn't count as a negative contrast study. It's only if it's undiluted contrast. And we'll go through that pathway again a little bit later. So again, so this is gastrographin. That is a non-water soluble contrast. We use Omnipaque at our hospital, which is water soluble. And both have been studied, whether it's water soluble contrast or non-water soluble contrast. Both are effective in diagnostically telling if the patient will be successful with non-operative management. There is also some belief and probably some evidence, at least with the gastrographin, which is high osmolar weight, that there is a therapeutic benefit from the undiluted contrast. Because the contrast has a high osmolar weight, theoretically, it pulls fluid from the abdominal, from the bowel wall into the lumen, reducing edema. And by reducing edema, it promotes resolution of the bowel obstruction. That hasn't been proven mechanistically, but in retrospective studies, patients who get the small bowel pathway tend to require surgery less often. So there's a theory that there's a therapeutic benefit to these pathways. But they are pretty well studied at this stage. It is giving undilute oral contrast via nasogastric tube, or in the rare case where you have a patient who does not have a nasogastric tube, they can drink it. And then obtaining a KUB. This one says at 4 hours and 24 hours. We do at 8 hours and 24 hours, whatever your pathway would be. Excuse me. And then if you see contrast at one of those time points in the colon, and this is a very clear picture of contrast in the colon, you can, with very good sensitivity and specificity, say, this patient is very likely to resolve their bowel obstruction without surgical intervention. And in fact, our pathway is, if we see this X-ray, we pull out their NG tube, we tell them to eat, and we discharge them either that day or the next day. And we have very few readmissions from that. Now, the converse, the opposite of that, is not necessarily true. So if contrast does not reach the colon at 24 hours, that does not mean with certainty that they will fail non-operative management. So the negative predictive value is not as good. So usually what I say is, it is unlikely that they will be successful with non-operative management, but it's not certain. And so then you go back to like we used to do. We look at the patient, we look at the, have they had 20 laparotomies and I really don't want to give them another one, and let's just wait a couple more days and see if this resolves. That's perfectly reasonable. That's the patient you wait the 3 to 5 days on. If they've never had a bowel obstruction before, this is the first time, contrast doesn't pass, they're anxious to get out of the hospital, I will usually say, hey, look, we could wait and there's a small chance this will get better. or we can go to the operating room and we can take care of this now, accepting that there is some risk from surgery. In most studies, using a pathway, any pathway with oral contrast, reduces hospital stays. And I think in everyone's environment, in your environment and in our environment, having fewer patients in the hospital is beneficial. So laparoscopy, we talked a little bit about, but yes, Markian, go ahead.
Could I ask you if I'm correct, gastrografin, you could not use gastrografin in pregnant women. Do you have any alternative for that?
I have not heard that myself, but if you cannot, the Omnipaque, which is what we use, is considered a low osmolar weight water soluble contrast, which I'm pretty certain is perfectly fine in pregnant women.
Okay, thanks.
Yeah. There's also the concerns for aspiration. We haven't really talked about that because these contrasts can be caustic to the lungs if they're aspirated. My personal preference is that every patient with a diagnosis of small bowel obstruction should have a nasogastric tube. In our institution and in a lot of institutions, people will often say, oh, but they're not throwing up and they're not nauseous. Let's not put an NG tube in them. Let's just wait. And I always push back on that. I believe that the nasogastric tube will benefit them if they do have a bowel obstruction. They might not be nauseous now, and that's probably because they threw up an hour or two ago and now their stomach is empty, but it will refill again. And so relieving that pressure will have some benefit. And that also, I think, reduces your risk of aspirating that enteric contrast because you could put it down the NG tube instead of having them drink it. So the discussion of laparoscopy versus open surgery, again, the most important thing is, do you have the facilities and the equipment and a surgeon who is comfortable performing laparoscopy? The bowel obstruction itself is less critical. Some of our surgeons who are very comfortable with laparoscopy, even more comfortable than they are with open surgery, might take a patient who's had 10 laparotomies, who you expect is going to have dense adhesions, and they might spend a few hours doing that surgery laparoscopically. And in general, it is perfectly safe to do that. And it's reasonable first-line therapy by all guidelines that exist right now. In the largest series, more than 500 patients, there were 4.7% enterotomies, and 1% of those were missed. There's a higher rate of enterotomy in the laparoscopic group, but it's important to notice that those enterotomies usually occurred after those patients were converted to open. So the enterotomy probably isn't because they use laparoscopy. The enterotomy was probably because there was a really hard case that required conversion to open. Hopefully that makes sense, but it really does come down to what your comfort level is. And I will tell you from experience that an open laparotomy for lysis of adhesions is very straightforward. It's very satisfying, but that patient is always going to spend at least 3 days in the hospital and up to a week or two, depending on how much work you do. And most of their stay is for pain control from the laparotomy and waiting for their ileus to resolve because of all the manipulation you did. If you can do the same surgery laparoscopically and the patient has 3 5-millimeter incisions and very minimal handling of the bowel, that patient often goes home the next day. So there's a very big benefit as far as pain, as far as ileus, and as far as hospital time, if you're able to safely do it laparoscopically. Can I ask you guys, since I have never practiced in Ukraine, is laparoscopy for small bowel obstruction a common or uncommon?
Nope.
Clear
In
rate.
our
Common.
institution, I've never seen a laparoscopic intervention during small bowel obstruction.
So it sounds like it's, in general, it's pretty uncommon. I will say, I am not one of those guys that is fantastic with laparoscopy. I do it, because there are certain things we have to do. But when I am able to do it for small bowel obstruction, the outcomes are much better. Just the patients have so much less pain. The patients resolve their ileus the next day. It's generally much better if you can. Commonly, what I will tell patients is after laparotomy for small bowel obstruction, you will have an ileus. So you won't wake up and not feel like you have a bowel obstruction anymore. This isn't one of those cases where, oh, thank God, it's all better now. You will wake up and you will still have abdominal distension. You will still have nausea. You will still have discomfort, except now it will be because of ileus, not because of small bowel obstruction. That ileus will last, I usually say, for about as long as your bowel obstruction lasted. So from whenever your symptoms started until you have surgery, it will probably take about that long until your ileus resolves and you're ready to go home. So if you've been waiting on your operation for 3 days or 5 days, expect you're going to wait for another 3 days or 5 days before you're ready to leave the hospital. And I also say every patient is different. It may take longer, it may take shorter. I have seen it take 3 days and I've seen it take 3 weeks. So predictors of success with laparoscopy, fewer laparotomies, less dilated bowel, and if the prior surgery was something really minor, like an appendectomy, then the likelihood that this is just one small band is much greater. Obviously, surgeon experience is important in this. You guys being the newer surgeons, now is the time you're going to start. You all know how to do laparoscopy. You've all done gallbladders and appendixes, I'm assuming, laparoscopically. So this is an opportunity to start changing practice as you see fit when you guys are in those decision-making positions. So at our hospital, we have a small bowel obstruction pathway. And as I said before, having a pathway in general improves patient outcomes, it improves patient flow and reduces length of stay. It's less important exactly the steps of the pathway, and it's more important that you have a pathway. So for us, this is an adhesive small bowel obstruction pathway, so it doesn't count if you have a hernia, doesn't count if you have abdominal cancer. And it doesn't count if you have signs or symptoms of bowel ischemia, because remember, that patient needs a surgery. We also don't do it in pregnant patients just because it's additional radiation, and we want to make those, we don't want to consider ourselves testing anything on pregnant patients. We do require a CT scan for all patients that we believe have small bowel obstruction. We obviously always complete a history and physical. We get labs that include chemistries, lipase, lactate, and complete blood count. And we get a CT scan without oral contrast if we are concerned that they have bowel ischemia, they get a surgery. If we do not believe there's bowel ischemia, they do get an NG tube, Foley catheter, IV fluids. The head of bed 30 degrees is honestly more important than we give it credit. Again, aspiration is one of the leading causes of complication in small bowel obstruction. So we want to do what we can to prevent aspiration. We can never completely prevent it, but we can do our best. Serial abdominal exams. These are patients that have to be seen at least every 4 hours. Daily labs. And then we have an omni-PAC protocol, which is our low osmolar weight oral contrast, water soluble. 100 cc's, and for us that's 2 bottles down the NG tube. We clamp that NG tube for 1 hour and then return the NG tube to suction. and get a KUB at 8 hours and 24 hours. We do that after an NG tube has been in for a little while to make sure we first empty the stomach, then put in the contrast and clamp it, then unclamp it and get imaging. This is what it looks like as a schematic, but it's basically what we just talked about. KUB at 8 hours, KUB at 24 hours. Has the contrast reach the cecum? And if it does, we take out the NG tube and start a diet. Doing this, we reduced our median length of stay by about a day, or roughly 25%. You will notice that there was an increase in mortalities in our SBO pathway. One, that was not significant, but two, that was just a really bad luck week where we had a few patients come in that aspirated and died. And readmissions are unchanged. That's really what I have to say. We have a little bit of time left, and I think the best thing I can offer you is my experience. If there is any questions you guys have, let's get to it and let's talk about it.
Thank you very much, Dr. Havens, for sharing your experience with us. We have several hands raised already, so
Yeah.
please, Dr. Chervonochenko. Yeah.
Yeah, maybe. Since I don't have the hands in front of me, if you can call.
Oh, I can help you.
Yeah, in whatever order you.
Yeah. Sure.
Thank you for your lecture. My question is about compromised bowel. If you see during an operation, if you see an ischemic bowel and the extension of ischemia and necrosis of the small bowel is really big. For example, you have about a meter or less of a viable bowel. Would you resect such a large amount of small bowel and put a patient under the risk of short bowel syndrome, or will you proceed with non-operative treatment, for example, anticoagulants and so on?
That's a great question. The first level of that is dead bowel will always be dead. It will not come back. So if that bowel is dead, then it has to be resected. And the more of this you do, the more you'll recognize, when you see it, the foul-smelling black bowel, that has to be resected, no matter what, small bowel, short gut syndrome or not. So if it is dead, it has to be resected. The next question is, well, what if it's maybe dead? What if it's possibly dead? So then my answer is often, if it is a small enough segment that I don't think they will have short bowel syndrome, I will resect it, even if I think it is possibly dead. If I believe that this will become life-limiting and that they may have small bowel short gut syndrome, then, and it is not obviously dead, what I might do is resect those parts that are obviously dead, and then leave that patient with a temporary abdominal closure, return them to the intensive care unit, allow them a day or two to resuscitate, to establish some hemodynamic improvement with antibiotics, with anticoagulation if there's thrombosis, and return in about 48 hours to see if that has progressed to survivable bowel or progressed to non-survivable bowel, and then go from there. So we use the trial of open abdomen and second look laparotomy, usually in those cases.
Thank you.
You're welcome. It's also a good opportunity to speak with the patient's family and ensure that you're acting in concordance with their wishes. So in those patients, there's a difference between the 22-year-old patient with adhesions and the 89-year-old patient with 3 different cancers. You may sit down with the family of a 89-year-old patient with multiple cancers and say, well, we've already resected half of their small intestine and we might have to resect the other half. is this something they would want to go through? And their answer might be, oh, no, that's enough. Don't do that. And that's a helpful piece of information to have. All right, who's next?
Thank you. Next, a question from Dr. Markian Nostri, please.
When do you let patients eat after the operation because of the adhesive bowel disease, with or without a bowel anastomosis?
That is a great question. I think, to be honest, my answer, whether they have a bowel anastomosis or not, I'm actually, that doesn't really factor into my equation, unless that's perhaps a duodenal anastomosis, but not, once you get into the small bowel beyond the duodenum, on any post-op day, that anastomosis should be safe. The question is, when do I believe that their ileus is resolved? That's a tougher one. Most of these patients, and as I said, almost all of them will have a nasogastric tube in. So my first challenge is the nasogastric tube output low enough that I think it can come out? And that is a judgment call, but usually I will say if it's less than about 1 liter, 1.2 liters of output, then we will try taking it out. If the NG tube output is low enough, if we remove the NG tube, then I will usually say all patients at that point can tolerate sips of liquid, less than 30 cc's, because that's not much different than just swallowing your saliva. Then it's more of a nuance, a judgment call as to when they can start eating more. Some people wait until there's some return of bowel function. So they might wait until there is passing gas. I will often just say, if they feel movement, if you hear bowel sounds, that usually means that their ileus is resolving, and I will let them have liquids at that point. But I always tell the patients very clearly, listen to your body. If you feel nauseous, that is your body telling you to stop eating. Most patients are good with that. Some patients don't have the insight and will keep eating. But if there is some signs of bowel function, even bowel sounds, I will consider that enough to start a liquid diet and then progress from there depending on how they feel. I don't base it on 1 day or 3 days or any particular time frame. I just listen to their bodies.
Thank you.
Yes.
Thank you. Dr. Havens, do you have a time for more questions?
Yes.
We
yes.
have a couple. Yeah, thank you. So, Dr. Alexander Buyarsky, a question, please.
Thank you for the lecture. I'm not sure my question is fully correspond to the topic of the lecture. What are the treatment tactics for functional obstruction in multiple organ failure patients? What type of nutrition should be used?
In patients who actively have multiple organ system dysfunctions, or in our critically ill patients?
Yes.
Great question. So a few things. As a general rule, I believe that enteric nutrition through the gut, is better than TPN, than parenteral nutrition. Not all patients can tolerate. So I will generally always try enteric nutrition. So even in a critically ill patient, even if they're on pressors, even if they are paralyzed, I will try enteric nutrition. Very slow. We might start at 10 cc's per hour and frequently check gastric residuals. If they're having bowel function, if their gastric residuals are not too high, then we will slowly advance that and try to get them to goal nutrition through their GI tract. So every patient effectively we will try. The only time I'll ever not do that is if they're on very high dose pressors, and I would have to pick something like 15 micrograms of epinephrine per kilogram. So if you were on a maximum dose of pressors, that's reasonable to not try enteric feeding. But otherwise, if you can always try, if their residuals are high, if they fail repeatedly to be able to advance their tube feeds, then enteral nutrition. I mean, parenteral nutrition.
Thank you.
Yeah, thank you. One more question from Dr. Bogdan Mikhailnuk.
Yes.
Thank you for the great lecture. Do small bowel intubation as a form of decompression have more benefits over simple nasogastric tube?
Say that again, small bowel.
Intubation.
More than nasogastric? That's a great question. I don't know that there's evidence to support it. What I will say is, if we place a nasogastric tube and we get an X-ray and it shows that that tube is in the small bowel, don't pull it back. I'll say, great, that's where we wanted it. Let that go. I don't know that there is evidence that that's the right decision, but it intuitively makes sense to me. So I don't make an effort to try to intubate the small bowel, but if it happens, I don't change that.
Okay, thank you.
You're welcome. I'm trying to stop this.
Thank you.
You're very welcome.
It was the last question for today. So thank you all for attention and participation today. And thank you, Dr. Havens, for finding time to share your expertise and to give this talk to us. I would like to wish you all a good evening, stay safe, and we are looking forward to our next session. Thank you all.
Thank you
Thank
guys
you.
for your
Thank
questions.
you.